Hello everyone, this is Dr. Rucha Dashrathi, a fellow under Dr. Jayaprakash Shah at Rajni Fetal Medicine Center, Ahmedabad. My topic for case presentation today is transposition of great vessels. So moving for our case for today, my patient Mrs. DNS, 35-year-old Gravida 3 Para 2 Life 2 came to us at 15 weeks and 4 days of gestation. Her ultrasound appeared grossly normal or her biometry was normal. However, her sequential segmental analysis revealed the following. As we could see in this videos, the situs was firstly confirmed that the heart was in the left and the stomach was in the left as well. Then the left and the right atrium and ventricles were identified. As we could see over here that the pulmonaries are entering into the left atrium, and the dirty chamber that we can recognize as the right ventricle over here, and therefore the left atrium is connected to the left ventricle and right atrium to the right ventricle. However, we could see that there is no crossover of the great vessels happening. We could see that two vessels are coming in parallel to each other from the outflow tracts. Moving ahead again, no crossover and parallel course of the two great vessels was confirmed. We were also suspecting a VSD in this case, and a 3-vessel trachea view revealed that only one single large vessel along with the SVC could be seen over here. Later on, at 17 weeks of gestation, we went for a microarray as we could see that there is no crossover of the vessel, so conotruncal anomaly was suspected as it was picked up quite early. That's why we were suspecting it to be a DORV of tossing wing variety, and hence a microarray was done, which came out to be negative. Going further ahead, at 22 weeks of gestation, the patient came back to us for a follow-up, and now this time the VSD was confirmed over here with the bidirectional flow of the Doppler. Again, the concordance between the atria and the ventricles was confirmed, and again the parallel course of the two great vessels was seen. The parallel course again could be seen of the two great vessels over here. The VSD again could be seen that a bidirectional flow was confirmed, therefore VSD was confirmed. And in the 3-vessel trachea view, again only one single large vessel along with SVC could be seen. That does not mean that another large vessel was missing. This vessel is supposed to be the aorta, and pulmonary was not missing, just was there below it. At 25 weeks of gestation, again, we could see that there is concordance between the atria and the ventricles, but the parallel course of vessels was confirmed, and again the VSD was confirmed. This led us to the diagnosis of DTGA with VSD, that is dextro-TGA along with ventricular septal defect. That was the report given to her, which said that the DTGA was noted and a muscular VSD was noted as well, and the concordance between the atria and the ventricle was confirmed. However, there was discordance between the ventricles and the large vessels. Coming on to case 2, my patient Mrs. SP, 22-year-old primigravida, came to us at 21 weeks of gestation with a malformation report referred from outside as AV discordance, that is atrioventricular discordance, VSD, single outflow, and abnormal 3-vessel view. Here, first of all, the situs was confirmed. The heart and stomach both are on the left side. Now, as we could see over here, we could see that the pulmonaries are entering into the left atrium over here, but it is connected to a ventricle which has moderator bands. So the left atrium is connected to the morphologically right ventricle, whereas the right atrium is connected to the morphologically left ventricle. Also, we could notice a VSD over here with a bidirectional flow. Moving further ahead towards the diagnosis, we could see the outflow tracts over here, and we could see that the non-bifurcating vessel, that is the aorta, is coming out of the morphologically left ventricle, which is situated on the right side, whereas the bifurcating vessel that we could see is coming out from the morphologically right ventricle situated on the left side. So this led to us to a diagnosis. Here we could see the bifurcating vessel coming out from the morphologically right ventricle on the left side. Also, we go to the three vessel trachea view. Again, we see a huge vessel, only one single vessel, and there is no SVC on the right side of this vessel. However, there is a vessel, that is a SVC, on the left side of this vessel, which gives us a diagnosis of persistently left superior vena cava, and the presence of the right superior vena cava was doubtful over here. Hence, we came to a diagnosis that this condition with the double discordance of atria and ventricles and the great arteries is a corrected transposition of great vessels along with the ventricular septal defect along with the persistent left superior vena cava. So moving on to the discussion part of this, what is transposition of great vessels? As per the definition, it is abnormal spatial arrangement of great arteries. Dextro-TGA, that is DTGA, has a single discordance, that is ventriculo-arterial discordance, but the atria and ventricle are in perfect association with each other. Whereas in congenitally corrected TGA, there is double discordance, that is atria as well as ventricle. Atria and ventricle are in discordance, as well as ventricles and the great arteries are also in discordance with each other. Now, moving on to the embryology part of it, as we know, there is bulbus cordis, which gives rise to the ventricles, while truncus arteriosus, which originates from the ventricles and divides into aorta and the pulmonary trunk. Now there is a bulbous ridge which forms the interventricular septum, and the truncal ridge which forms the aortopulmonary septum. Now all this forms the aortopulmonary septum. Now this aortopulmonary septum fails to spiral at the level of the infundibulum, therefore causing a linear development of the septum and therefore the transposition of great arteries. The looping is generally normal in case with the bulbar ridge, and therefore the right ventricle is on the right and the left ventricle is on the left, but the partition made by the truncal ridge, that is the aortopulmonary septum, is abnormal, and therefore the transposition of great vessels happens. Now DTGA. DTGA has, as we said, atrioventricular concordance, but ventriculo-arterial discordance is seen, as we could see over here. In a normal heart, we could see that the right ventricle is giving out the outflow of the pulmonary, which is bifurcating further, while the left ventricle is giving the outflow of the aorta. But in case of a DTGA, we could see that the atria and the ventricle, however, if they are in concordance with each other, but the aorta is coming out from the right ventricle, while the pulmonary is coming out from the left ventricle, thus giving us a ventriculo-arterial discordance. So aorta and pulmonary, we could see over here that there is a crossing over of both of the vessels, but over here aorta and pulmonary both are parallel to each other. The position of the cusps of aorta and pulmonary, the semilunar wall has also changed, so the aorta is anterior and to the right of pulmonary. As we could see over here, aorta could be seen anterior and to the right of pulmonary. So the pulmonary valve, the semilunar valve, is anterior, lateral and superior to the aortic valve in normal course. However, in case of dextro-TGA, the pulmonary valve is posterior, medial and inferior to the aortic valve. Now dextro-TGA, it has a male preponderance of 2:1. It accounts to 5 to 7% of the congenital cardiac malformations. 4.7 cases per 10,000 live births have been researched of. Then extracardiac malformations along with it are, however, rare, but there is a 40% association with VSD. And it is cyanotic congenital heart disease. Now, why is it a cyanotic congenital heart disease? As we could see in a normal circulation, a left ventricle, in a normal circulation, left ventricle is going to pump out blood. If we start off from left ventricle, it pumps out oxygenated blood to the body through the aorta. Okay, it will go to the body, and then the deoxygenated blood comes back into the right atrium, goes to the right ventricle, from the right ventricle to the pulmonary artery, again which goes to the lungs for oxygenation. It is oxygenated there and then goes back to the left atrium and again to the left ventricle, and this circuit continues. So these two separate circuits, that is the pulmonary and the systemic circuits, run hand in hand to each other for a normal circulation. But in case of a dextro-TGA, due to this discordance, what we see is the pulmonary and the systemic circuits both are not working in hand with each other, but are forming two separate circuits working individually. So what happens is that deoxygenated blood that is coming from the body is going to the left atrium, again to the left ventricle, to the pulmonary and pulmonary artery from over there, but pulmonary is not taking it to the lungs, and therefore this deoxygenated blood again keeps running on into the body. Whereas in case of the right side of the heart, the right atrium is taking the blood to the right ventricle, then to the aorta, back to the lungs, oxygenated over there, again comes to the right atrium, right ventricle, and the cycle continues. So the oxygenated blood keeps moving just in this pulmonary circuit over here, and therefore the body is getting supplied with deoxygenated blood, therefore leading to cyanosis further. However, in utero, there won't be a problem. The fetus won't have any symptoms as it does not use its lungs for breathing. And therefore, also there are certain shunts that are present over there, like the ductus venosus, the foramen ovale, and the ductus arteriosus that we could see, which cause the intermixing of blood and keep the two circuits running hand in hand with each other. However, these shunts are going to close after birth. They are going to close and form certain ligaments, and therefore the process of the systemic and pulmonary circulations working separately is going to start, and the cyanosis is going to happen. And therefore, if in such cases, if there is a patent foramen oval or a patent ductus arteriosus or a ventricular septal defect, that is a high association with DTGA, it is going to be helpful, producing a good outcome, because the intermixing of blood will keep happening through these shunts. Coming on to the USG findings, so normally in case of DTGA, as we said, first we have to confirm the situs. After that, we could see that there is atrioventricular concordance, that is left atria and left ventricle concordantly connecting each other, right atria, right ventricle concordantly connecting with each other. So there will be a normal, unremarkable 4-chamber view in this case. There will be, however, no crossover of the vessels. The aorta and the pulmonary coming out from the ventricles will be seen in a parallel course with each other. So a parallel course of vessels will be seen. If we go on to the outflow tracts, we will see that there will be a vessel coming out from the right ventricle, which will not be a bifurcating vessel, but another vessel coming out from the left ventricle will be a bifurcating vessel, indicating that it is a pulmonary artery. Therefore, pulmonary artery arising from the left ventricle, that is the left outflow tract, and we could see that it is a thick vessel and immediately bifurcating into right and left branches, and also the left branch is directed towards the spine. Going on to the 3-vessel trachea view, we will see a single large vessel with SVC on the right side of it. This single large vessel is aorta. That does not mean that the pulmonary is not present, but due to the parallel course of vessel, the pulmonary has just been situated below the aorta. We could see the aortic convexity towards the right, giving it a sad face or a smiley face appearance. That is a sad sign. Now, as we could see over here in this video, we will be able to see that there is a concordant atrioventricular concordance. The pulmonaries could be seen entering into the left atrium, and as we move towards the outflow tracts, we will see a parallel course of vessels. The bifurcating vessel was seen coming out from the left ventricle, the bifurcating vessel, as we could see from the left ventricle. Going on to the management on outcome of this. First of all, if we have detected a dextro-TGA, we look for other cardiac anomalies. Association with VSD that is high has to be looked for. A scan for other extracardiac malformations has to be done. Karyotyping, however, is not indicated in this case, but like for our case, we did it because we found it quite early on and we were suspecting a DORV of the tossing wing variety. Also, 22q11 microdeletion has a very high association with conotruncal anomalies. Then serial follow-up scans have to be done to confirm the diagnosis, also to see if the VSD is present or not. A compulsory scan has to be done at 36 weeks of gestation in case of intact ventricular septum to look for a restrictive foramen ovale, so the line of treatment could be decided early on. More than 90% of long-term survival rate in such cases with DTGA along with VSD is present. So going on to the medical management of it, prostaglandin even infusion could be given to keep the ductus arteriosus patent, which will be a shunt for the oxygenation to keep happening for the intermixing of the two circuits that will happen. Now, if in case the VSD is not associated, we will need an emergency procedure to be done for the foramen ovale to be enlarged or to stay patent. So what is done is the Rashkind's procedure in such cases. In the Rashkind's procedure is a balloon catheter procedure in which the balloon catheter is guided into the right atrium through a large vein catheter which is threaded into the foramen ovale, and the balloon is inflated to keep the foramen ovale patent or to enlarge the foramen ovale cavity over here. This is called as balloon atrial septostomy. Now this is a picture of the atrial switch operation. Now what happens in this case, that there is the transposition that has happened, that of the aorta and the pulmonary is refixed. So what is done is there is cutting off of the aorta and pulmonary above the point where they leave the heart, and repositioning of them is done. That is, aorta is put back to its original position and pulmonary is put back to its original position. Also, the coronary arteries are also cut off and repositioned into their place over the aorta. Now moving on to CCTGA, it is a double discordance, that is atrioventricular discordance and ventriculo-arterial discordance, as we already saw in the pictures. It accounts to about less than 1% of the congenital heart diseases. Then virtually there is absent risk of chromosomal and non-chromosomal anomalies. It is isolated in only about 9 to 16% of the cases. The associated cardiac anomalies with it are VSD, pulmonary outflow obstruction, tricuspid wall abnormalities, dextrocardia or mesocardia, and rhythm disturbances. It is associated with extracardiac malformations like renal malformations most commonly, and this one is an acyanotic condition unlike dextro-TGA. As we could see over here, the normal course where atria and ventricular are concordant as well as the great vessels are concordant. In case of DTGA, the great vessels are discordant, and in case of levo-TGA or CCTGA, there is atrioventricular discordance as well as ventriculo-arterial discordance is also seen. Now in this case, the aorta is anterior and to the left of pulmonary artery, unlike the DT. Now the embryology behind this is that there is abnormal left looping of the bulbous cordis along with failure of a spiraling of the truncal ridge. Now this is an acyanotic condition. Why? Because even if there is a ventriculo-arterial discordance, along with it there is also an atrioventricular discordance, and therefore even the ventricles have switched their places. Therefore, the pulmonary and systemic circulation keep running together even though there is a discordance in both cases, and therefore making it a acyanotic condition. Going on to the USG findings, so in case of CCTGA, we will see that first we'll confirm that there is the atria and ventricles are concordant, as we could see over here. The pulmonary veins are entering over here, so it is the left atrium, but the dirty chamber over here, therefore the right ventricle. So the morphologically right ventricle is situated onto the left side, morphologically left ventricle is situated onto the right side. So the left, as explained, left atrium tricuspid valve connecting to the morphological right ventricle, whereas right atrium mitral valve connecting to the morphologically left ventricle. The apex of the heart here is formed by the right-sided ventricle and not the left-sided ventricle. The moderator band, as we could see, was there in the morphologically right ventricle, situated on left. Going on to the outflow tracts, we could see a pulmonary arising from the morphologically left ventricle, a thick vessel arising and bifurcating further ahead, and also aorta arising from the morphologically right ventricle and coursing to the left hemithorax. There is again absence of crossover and both these vessels run parallel to each other. Now in CCTGA, first we confirm the situs, the baby is in breech presentation. Now the heart, if we see, we have to confirm the left atrium which is connected to the right ventricle, morphological right ventricle, whereas right atrium are connected to morphologically left ventricle, as we could see. Now we could see the crossing over of vessels again, no crossing over of vessels again, and we could see a bifurcating vessel coming out of the morphologically right ventricle, whereas a non-bifurcating vessel coming out from the morphologically left ventricle situated on the right side. And hence the diagnosis of CCTG is confirmed. Now, in a case of management, again, fetal karyotyping is not indicated. Congenital heart block, however, is to be looked for in the third trimester and at birth. Then look for the associated cardiac and extracardiac malformations and screen for 22q11 microdeletion due to its high association with conotruncal anomalies. Why would a heart block take place? That is because congenital heart block at birth will take place as the conducting system is disturbed. Due to the ventricular discordance, SA node, though lies in the right atrium, AV node and the bundle of His is unusually positioned, and therefore conduction disorders could be there, leading to a heart block. However, this condition is going to have a good outcome. Poor long-term prognostic factors are Epstein malformation, then degree of tricuspid regurgitation, systemic right ventricular dysfunction, and complete heart block. The reason behind this complete heart block again is that the right ventricular dysfunction will be there. The right ventricle is built for a low pressure pulmonary circulation and left ventricle is built for a high pressure systemic circulation, but they are working completely the opposite way, and therefore the right ventricle won't be able to cope up so much, therefore creating a right ventricular dysfunction, which starts off a tricuspid regurgitation, later on leading to a complete heart block. So the management for a CCTGA corrected TGA will be a double switch operation, also called as the Senning mustard atrial switch along with arterial switch of great vessels. That is, two switches, atrial switch along with arterial switch. So arterial switch will be similar to that of DTGA, where pulmonary and aorta were repositioned. However, in atrial switch, the right atrium is opened, the atrial septum is removed, a tunnel is created to drain the blood from IVC and SVC through the tricuspid valve to flow into the right ventricle, which is then taken up by the pulmonary, the neopulmonary, to the lungs. Now the deoxygenated blood goes through the lungs through the neopulmonary, while the oxygenated blood to the body through the neo-aorta. So a difference between DTGA and CCTGA. DTGA will have an AV concordance will be present, while in CCTGA AV discordance will be present. Ventriculo-arterial discordance in both the cases. The systemic veins drain into the right atrium, while in CCTGA drains into morphologically right ventricle. Then pulmonary artery comes out from the left ventricle in DTGA, while in CCTGA it is transposed and arises from the morphologically left ventricle. The aorta, it is anterior and to the right of pulmonary artery in DTGA, while in CCTGA it is transposed and arises from the right ventricle, and it is anterior and to the left of the pulmonary artery, and hence this condition is called as levo-TGA. The pulmonary veins drain to the left atrium in DTGA and drain into the left atrium again in CCTGA as well. The interventricular septum may be malaligned in case of CTGA, and in the case of USG findings, both have parallel vessels. Moving on with the differences further, as we know in DTGA there is only a single discordance of the ventricles and the great arteries, while in CCTGA there is a double discordance of the atria and the ventricles and the great arteries. Hemodynamically speaking, DTGA is a decompensated condition, whereas levo-TGA or CCTGA is a compensated condition. The oxygenated blood is going to flow to the pulmonary circulation, while the deoxygenated blood in case of CCTGA is going to flow in the systemic circulation, and the unsaturated blood is going to flow into the systemic circulation in case of DTGA, while in case of CCTGA exact opposite, it will flow through the pulmonary circulation. That's all. Thanks for your patient listening. Thank you so much.